Good day, and welcome to today's webinar, The Impact of Natural Disasters on the OR, hosted by the International Relations Committee of the American College of Surgeons. My name is Jessie Von Custer. I'm the Program Administrator for the IRC. Before we get started, I wanted to inform everyone that the webinar will be recorded and will be available for viewing on the ACS YouTube page after the webinar. Additionally, if you have any questions during the webinar, you may submit them through the Q&A box at the bottom of your screen, as there will be an audience question and answer portion at the end of the webinar. With that, it is my pleasure to introduce you to today's moderator, Dr. Rhea Liang. Dr. Liang is a general breast surgeon on the Gold Coast of Australia. She is a systems change leader, a medical educator, and the clinical subdean at Bond University. She researches, advocates, and consults on breast cancer and inclusive excellence issues. She serves on the British Journal of Surgery's editorial board and the American College of Surgeons International Relations Committee. Dr. Liang chairs the sustainability pillar as a member of the clinical council for her hospital, and she's on the steering committee of the Greening Healthcare Forum for the Climate and Health Alliance of Australia. With that, I'll now turn it over to you, Dr. Liang. Dr. Liang?
Thank you so much for that generous introduction, Jessie. Thank you everyone for joining us today and the American College of Surgeons International Relations Committee for the webinar on the impact of natural disasters in the OR. I'll start by introducing our three speakers, Dr. Sally Butchers, Dr. Howard Pryor, and Professor Wakaina Betty. And we'll then proceed on to their three presentations and finally end with a question and answer portion with all three speakers and myself as a full panel. So to introduce our first speaker, this is Dr. Sally Butchers. Dr. Butchers is a general surgeon with an interest in rural surgery training and education. She's the current president of General Surgeons Australia, and in this position, she's going to continue the advocacy work she did as the chair for the rural section of the Royal Australasian College of Surgeons. When we planned this webinar late last year, I actually asked Dr. Butchers to speak about the effect of the floods that had affected her hospital in 2022. But we've both actually in two separate states been affected just a few weeks ago by the same cyclone, Cyclone Alfred. I'm very much looking forward to Dr. Butchers' presentation about how it affected her hospital in Lismore. Our second speaker is Dr. Howard Pryor. Dr. Howard Pryor, the second MD, is a paediatric surgeon and a surgical critical care specialist with extensive training and expertise in managing complex surgical conditions in children. Dr. Pryor has been actively involved in medical education and research, publishing numerous surgical textbook chapters and peer-reviewed manuscripts throughout his career. He's presented his work at national and international paediatric surgical trauma and critical care conferences. And during his naval career, Dr. Pryor was committed to humanitarian aid and disaster response, leveraging his pediatric surgical expertise. He received commendations and humanitarian service medals for his exceptional service. So at the moment, Dr. Pryor is an associate professor of surgery at Baylor College of Medicine and trauma medical director at Texas Children's Hospital. His research interests include the impact of surgical nutrition on wound healing in trauma patients and non-invasive monitoring strategies for managing traumatic brain injuries in children. And our final speaker today is Professor Wakaina Betty, who is a general surgeon and a professor at the University of Fiji Suva campus in Suva, Fiji. Professor Wakaina Betty is a former Minister of Health in Fiji, and as Minister of Health, he coordinated Fiji's COVID pandemic response and has assisted in disaster response during natural disasters such as cyclones. And certainly Sally and I will be very keen to learn from him about his learnings in a low resource area. So a very warm welcome to our three speakers. Having introduced our panelists for today, all yours, Dr. Butchers.
Oh, sorry, my wake-up alarm just went off. I do apologize. I'll just start sharing my screen and then go into presenter mode. Is that all looking good? Can you hear me? Yep. All right. So thank you very much, Raya, and the International Relations Committee of the American College of Surgeons for asking me to speak today. I've been asked to speak on flood disasters and the impact on surgical services. This is the Lismore experience from 2022. No matter the size or extent of a natural disaster, their impact is profound and often far-reaching. Lessons learned can be vitally important in focusing future responses, as sadly it is not if something will happen again, but when. One of the other things that I think is really important is surgical services is more than just what's happening in the operating suite. So some of my talk will be concentrating on that. This slide shows the Northern Rivers where I live and in New South Wales, which is just below where Dr. Liang lives in Queensland. And it's not entirely evident in this slide, but it's based on the conversion of 5 river systems, which has made us flood prone. Lismore's in the centre of the area here. And then we've got rainforests around the side. We've got lots of farmland and orchards in the middle. And we come down to the coast here, which is Ballina. We have about 45,000 people in the area, but the entire catchment, which is a lot wider, has 120,000 people. On February the 28th of 2022, our community was turned upside down. Certainly not on the scale of some other disasters around the world, but it was equally devastating for our community. And those who were directly affected by loss of everything, or others like myself who were indirectly affected. The floods came down to Ballina, which was also being impacted by a king tide, which meant that the flooding was going up and down, and some people's places were in fact inundated up to 6 times. This slide here shows the history of flooding in Lismore, so it's well known, and in fact our Indigenous population tends to live on the plateaus rather than down in the centre for good reason. On the end here, we can see the 2022 flood at 14.4 metres. It was way over what was expected, and also quite rapidly followed by another levee breaching flood within a month. No one really had predicted what was going to be happening. And though our community is set up for floods, this one had exceeded all previous floods and was not expected. Okay, sorry. This is a photo of one of our main streets. The flood came up rapidly. We had faulty reporting equipment, so the predictions were not accurate. We were expecting the flood at 10 a.m. It came at 10 a.m., so in the middle of the day, but it came at 2 a.m. and it was much higher than predicted. Our emergency services were overwhelmed, and we ended up having a community response. And a lot of these vehicles are tinnies or just small boats that the community were manning and going around and saving people, rescuing as many people as possible from trees, from rooftops, and from being caught in attics. And there were a lot more harrowing tales of people escaping the floods. Unfortunately, we did lose 5 people in the floods, but without this community response to aid our emergency services, we would have in fact lost a lot more. As you can see from this slide, there was a huge impact in Lismore. This is our McDonald's in this bottom left photo here. You can already see that it's elevated because of previous floods. But then when you look at the next slide, the flood level only just left the golden arches floating on the top. So it was well and truly into this second level, upper level. And that was a problem in our art gallery where things had been moved up. We lost a lot of artwork, our libraries. And in fact, businesses that were affected were 6 out of our 8 pharmacies, 13 GP and specialist practices. The helicopter retrieval service was down in the floodplain, which is something that is now going to be rectified. Ambulance services, nursing homes, our regional airport, 3 of our major food outlets, the main telecommunications substation. Again, things were moved to the second floor, which was inundated for the first time. Fuel stations, and we had issues with electricity supply. Both the public and private hospitals in Lismore were on generator power. Ballina Hospital, one of our coastal peripheral hospitals, had to be evacuated to a local high school at short notice. And accommodation was severely impacted for not just staff, but patients. And it caused issues with being able to safely discharge patients when suitable. So the hospital itself was quite overwhelmed. The telecommunications breakdown impacted on all areas, particularly with the flow and effect to the hospitals. We had difficulty coordinating responses and record keeping. We had issues with our health reporting within the hospital, as it's all computer-based now. And we, in fact, also had problems of families trying to find their loved ones. We were often relying on anecdotal tales to be able to help people find their loved ones. The impact on Lismore Base Hospital itself, it wasn't directly flooded as in the building, but there were, as you can see, a lot of areas that were impacted. We had issues with shortage of staff. Some of them were isolated with road closures. Many had their homes flooded and were evacuating families of 6 children in tinnies with nothing but what was on their back. And those working in hospital couldn't actually get home or had no home to go to at the time. I've mentioned the issues with the power supplies and the computer services in the hospital, and also having very limited mobile phone coverage. Accident emergency was overwhelmed with people, dialysis patients coming in, nursing patients being transferred in as they had nowhere else to go. And we had the disaster affected people coming in with exposure and other injuries, and also the routine medical care that most people would get from their GP practices couldn't be provided, as those practices were inundated. So they came to the emergency to get regular scripts and aid that's not normally provided via emergency. As the cleanup progressed, so did the injuries and infections, and therefore the workload. With regards to the operating theatres, we had elective surgery cancelled for 5 weeks, and this didn't even happen during COVID for our area. We were quite lucky from that point of view. It meant that our Category A cancer patients weren't getting their surgery in an appropriate time. We normally have 8 theatres, 2 endoscopy suites and 2 peripheral site theatres, but we were down to 1 theatre initially, and then were able to service 2. The other 5 theatres in our private hospital were not up and running either. You don't think of things like pharmacy, but drugs become a huge issue. We had 2 surviving pharmacies out of 8. They were not just supplying the community, but the hospital as well, and multiple evacuation centres needing help. Stores and catering became an issue. The area ran out of food at day 4. Dressings, PPE, and other sort of medicines were in short supply. Our hospital cafeteria was closed, but we had to continue to feed patients and staff that were in the hospital. Bed blockages was a huge problem. We couldn't safely get people out. There weren't nursing homes to transfer, and our peripheral hospitals were also, in fact, affected, which meant we couldn't transfer patients out to them to free up space in the main hospital. Code Brown, which is the hospital facilities health response to a major external injury incident, wasn't initially called, which to a lot of us was surprising. It was called when there was a major mudslide, and we were expecting mass casualties, and we prepared as best as we could. Unfortunately, the only casualty was someone who had died, and it wasn't a mass casualty. So having tried to get prepared for that, which was something we hadn't really done for a while because a lot of the practices during COVID weren't happening, it was a timely reminder of needing to improve our capabilities. Evacuation centres become a hotbed of demand that's not met. There were not enough beds, no power, limited security, injuries that needed caring. We had teams that were rostered on by Medicine Sans Frontières, experienced doctors, to help all those volunteering provide services around the hours, 24 hours. Mental health issues and drug and alcohol issues ended up being a big impact, and Valium became a very important drug that was needed. Again, record keeping became an issue. There's lack of counselling and lack of medical supplies. The COVID impact then hit not too long afterwards, as we weren't able to isolate any patients, and the mental health aspect of a lot of those that were left not able to go to family or other areas meant isolating them was having a big impact on them. Even something as simple as our breast screen bus was moved from one flood-prone area to an area that didn't normally flood in Lismore. And of course, it got lost. So that's a huge cost to the local services, but financially because of all the equipment that's in the buses. So that, and even community cars were lost as there wasn't time to move them. I suppose this is what I was really asked about, was the impact on the surgical caseload. I've mentioned that we didn't have any elective surgery for 5 weeks. All subspecialties had a reduced capacity. Emergency work was mainly orthopedic and general surgery, soft tissue and bony injuries. We had a reduction in theatre minutes staffed that was down 500%. Theatre minutes actually used was down 400%. And overall, there was a 50% reduction in theatre attendance. Pre- and post-operative hospital care was an issue, and having staff that were both victims and responders is common after major disasters, and provides a difficult thing for hospitals to, or all medical staff to deal with as well. And bed availability, as I've previously mentioned, was very difficult. Another impact that was found from the research that we did after the floods was there was an impact on surgical training. And having gone through the previous 2 years of COVID and the impact that that had, we were slowly starting to pick up again in 2022. After the Christmas slowdown, things were improving, and then we got hit with the flood. Now, a lot of the surgical registrars and medical students were deployed in other areas. They helped evacuate the Ballina Hospital when that was required. They went to the evacuation centres, and one of the ED emergency FASMs said that they may not have been learning surgical skills, but they were learning a lot of life skills that was important. And I think all of them, in fact, felt that they gained a lot from the experience. The impact on the future, and Dr. Liang pointed out that we've recently been through a cyclone. things that were done differently this time was we preemptively shut down elective surgical services, which meant that the hospital itself could get prepared for what may happen, and also that the staff could go home and prepare their homes as well. We'd worked out the most effective communication channel was to set up a WhatsApp group. So several different WhatsApp groups were set up in surgery, in emergency, and with the physicians. We had bolstering of catering and supplies, equipment, which again just is with the nature of the cyclone versus the flood. The prediction, and we had several days to prepare, which was very different to the 2022 incident. And we did have a mass casualty, which we had been able to do a practice or a simulation in the intervening 3 years. One or two of our military vehicles, top heavy in sort of known territory, rolled over. One rolled over down a hill as it avoided the one that had rolled over in front of it. And so we actually had the emergency department cleared, the staff that was available. It was actually an emergency handover time, so we had 2 sets of emergency staff, and the triaging, the management, and thankfully the seatbelts that limited the injuries to the, I think it was 36 military personnel. It was dealt with in a really fantastic way, which it was good to see that we had learned some things out of our 2022 disaster. This photo shows one of our main bridges into town with the Tinny Brigade working. They'd take them over and up the hill to the ambulances that were waiting for them. Shows one of our evacuation centres, and it shows a community that pulled together in the event of an unprecedented disaster for our area. I would like to acknowledge some of my colleagues, in particular Dr. David Townend, who provided the photos for me, Marianne Sewell, who was our trauma CNC, who helped collate a lot of the data, and John Hugh, who has a paper ready with information and data to have someone publish if we can find someone to publish it, but it actually has a lot of interesting information on a regional community that was affected in an unexpected and over the, I suppose, top way by the floods that we'd never seen before. So thank you very much for that, and I hope this has given you some insight on how we as a community managed a difficult situation and how we've taken it forward to improve the services that we can provide for our community in a disaster zone. Thank you.
Dr. Butchers, that was amazing. And I learned so much from watching that. It is, of course, likely that we're going to be meeting more of the same events. And of course, both of us are on the same East Coast, although in different states. So we must all learn from each other. A reminder to all our attendees that there's an audience Q&A at the end of all the presentations. So if you have a question for Dr. Butchers or any of our presenters during this webinar, please make sure to submit your question through the Q&A box at the bottom of your screen. So with that, I'll now hand over to Dr. Pryor.
All right. Is that sharing appropriately? It looks like it is. Thank you all for the invitation to speak. I appreciate the opportunity to share some of our experience for some of the impacts we've experienced here at Texas Children's Hospital. We are a pretty large hospital. We see about 175,000 ER visits a year. We have 973 beds here. We do about 43,000 operative cases a year and have about 275,000 patient days in our facility, over 35,000 admissions. So we are busy. And we have things scheduled out pretty far into the future. So when a disruption occurs, it has lasting effects for some time. We have 4 campuses now in Texas that serve a geographic region about the size of the state of Georgia in the United States. And I work primarily at the Houston main campus, but we have 2 other campuses in Houston and 1 in Austin, Texas now. We are about 35 miles inland from the Gulf Coast, and I have actually lived on the Gulf Coast for a significant portion of my life in both Florida and Texas. And we see hurricanes with a great deal of regularity. Hurricanes here, cyclones in the Pacific. Our biggest problem that we have when a hurricane is approaching is figuring out can our OR teams get to the hospital when we're going to need to do operations. When we had Hurricane Harvey come through, this was our primary problem. We kept having, there's just flooding everywhere here. We are also flood prone. We live on a region that has 5 bayous. They're not exactly rivers. They are estuarian waterways where the flooding actually can get worse, again, also with titling, as was mentioned before. And so Hurricane Harvey hit on August 25th, and between then and September 9th, we had some 430 surgical cases that were fully canceled. All of our outpatient surgery was what was mostly canceled at that point. The inpatient stuff was addressed by teams that were in-house, and we continued to take those kids that needed serial operations to the operating room. The primary reasons were, of course, weather, traffic, and or something along the external disaster category, like people literally had their car destroyed, or their house was crushed by a tree and they needed to attend to their family. So the day of the surgery was the day of the hurricane was August 25th. We had 50% of our total canceled cases were between then and September 1st. But we had peak flooding due to a levee rupture in the Houston area on August 28th, and that actually impacted a greater number of cases, which was a secondary consequence of all of the rain from Hurricane Harvey. I will say Hurricane Harvey was an unusual hurricane in the sense that it literally just parked offshore and dumped water, and then finally hit land. And all that water accumulation was just terribly detrimental to our levee system here, and eroded the largest levee in the region and flooded one of the main bayous here. It was a relatively rapid flood of Buffalo Bayou, and you can see cars literally just got engulfed in a very short period of time and with relatively short warning. We then subsequently in June of 2024, we had Hurricane Beryl, which affected our region as well. Less flooding in that particular hurricane, but still lots of water in the area. And the things that we learned from Hurricane Harvey that worked well and that have been implemented and used in subsequent hurricane disasters is what I'd like to share. First off, we developed kind of a system-wide culture of preparedness where we first off started from this very front standpoint that every single worker here is an essential worker, and we will have a need for everyone to be on one of 3 teams, either the prep team if we know a hurricane is coming, what we call the ride out team, and then the cleanup team on the back end when we're trying to figure out how to address all of the individual losses that we might have had. Our facility itself is pretty hardened, and you can see here that we set up on one of our auxiliary bridges services for staff that were living in the hospital during the actual storm itself. We had them come in. The ride out team arrived in advance after all of this stuff was set up by the prep team. They got an orientation, went through required training, and were taught about the ride out system before they even were needed. Then when we made the call, we notified the ride out team that had been selected for duty for the particular hurricane and had them arrive with a pre-packed grouping of equipment that we had recommended they have ready to go, like a go bag. And it includes all of this stuff here: a cell phone charger and some bottled water, some food that you like, although we have food services available here as well, changes of clothes, sleepwear, toiletries, etc. And have this kind of, if you're on the go team for a particular month, you're expected to just kind of have, or on the ride out team for a particular month, you're expected to have a go bag prepared already so that if you get a notification, you can just kind of get to the hospital and settle in. Second, we focused on staffing, making sure we had the right people in the right place at the right time for the type of functions and operations that we would expect the hospital to be engaged in. And then we set up some reality checks. People are going to be here on the ride out team, but not actually working. So we set up some things for them to do for kind of to have a little R&R. Our hospital is hard to conceptualize if you've not visited here, but it is 5 separate 25-story towers that are all interconnected without having to leave the building. And so we have spaces where people can be engaged in activities other than clinical care in a ride-out situation. Most of our clinical tower and office structure was used for housing staff. Sleep area, here's the ophthalmology clinic being used as a staff sleeping area. And this would be one of many clinic spaces converted to, shall we say, a hotel room, although that's very loosely described. And then we had an incident command center that was set up in the building as well, so that people were able to communicate directly with leadership about things as events were unfolding, both by phone, but also by literal physical interaction. We provided dependent care, recognizing that dependent care is a significant problem in these situations when people, particularly single parents, are required to stay in the hospital for a significant period of time. So we set up our child life team to help out by taking care of kids that were aged 5 to 12. They would have to be registered with dependent care if you were on the ride out team, but then when they got here, our child life team kind of took care of them and made sure that they were kind of engaged and safe. We had different arrangements we excluded people who were single parents of children under 5. And if they had kids that were in the 13 and up category, we had arrangements for them to stay with families that had kids in similar age ranges in the Texas Children's System. Obviously, we don't provide for pets and spouses, etc. Family members had to be arranged for in another location. This is what a standard kind of sheltering space looked like for dependent care, where both the parent and the child could sleep together in the same room, but that was kind of more of a large conference room type space. We also worked to reach out to our regional partners, not the least of which is Southeast Texas Regional Advisory Council, which is intentionally designed by the state of Texas to address disasters in our region. Here you can see this is our mission control center interacting with their mission control center, and they were integrating EMS services, news, data, weather, etc., to make sure that we were not faced with unexpected challenges as this hurricane disaster in Harvey and Beryl both actually kind of dragged on for a period of time in both cases. This is what our command center in the hospital looks like. This is the add-on room behind our normal transfer center, which behind these folks as they're facing away from us is a large room with our normal hospital operations center as well. And then complex care, there was no magic number of kids we would be able to take care of. We decided everyone was coming in if they needed to. We have lots of children that are technology dependent at home, and if they needed help, we decided they would be able to get here. We just told them to come early so we could get them set up. Here we have some Coast Guard folks who are helping out, entertaining one of our guys who's dialysis dependent, who came to the hospital for treatment during the entire kind of ride out period. Looking at other disasters, we've had wildfires in this region, nothing like the disasters that have faced other localities in the world. But in the one wildfire that we had relatively recently, this is generally a map of wildfires in America in general. Houston is located down here. That's the little orange dot at the margin between Texas and Louisiana on the Gulf Coast. We've had a couple of wildfires recently. The risks from wildfires in our region are kind of several. We have a lot of oil facilities in this region, petrochemical facilities. And when a wildfire strikes and it sets ablaze one of these facilities, that smoke is particularly toxic, obviously. So we have a lot of potential for asthma triggering and inhalational injuries in general here, prompting admissions to the hospital. Most of the time, that does not impact the operating room that much. However, occasionally we have had to put children on ECMO for inhalational injuries, and that does require operative services for a period of time. We also have a generator system that's capable of providing locally generated power for our entire hospital system to run without interruption, even if the grid goes down. So thankfully, while this type of wildfire in some communities would be disastrous were to impact the electrical system, our hospital will continue to function pretty much uninterrupted. We have a 3-generator system, so one is running, one is in maintenance, and one is on standby at all times. So the other thing that, of course, wildfires bring are burns, and lots of them. And kids are susceptible to them just as much as adults. These petrochemical fires, when they do occur, are radiate heat, even worse than merely just generating convective heat. They actually radiate a considerable amount of heat. If you stand next to a 6-foot-tall flame of hydrogen that's burning, you can be within a foot of it and be unaffected. But if you were within a foot of a 6-foot-tall plume of burning petrochemicals, you would pretty much be incinerated from the radiated heat alone. So we see this sort of thing, non-contact burns of one type or another. And that, of course, begins to increase your need for the operating room. Early excision and grafting is a standard practice for burn care here. We do smaller burns and have referral centers for the much larger burns. But in those cases, that starts to pick up your need to go to the operating room on a regular basis. So we work on bandaging for the immediate short term and then start doing early excision and grafting within 24 hours after admission, to the extent that we can handle that additional volume. Then the only other thing that we were talking about that's very germane to Texas are heat waves. Heat waves, basically every summer here is a heat wave. Our average temperature in July is somewhere around 110 degrees Fahrenheit. And so it gets very hot, and the humidity here is quite oppressive, to be perfectly honest. So kids that get left in cars, of course, are a problem, a trauma that we address probably several times a year. And these children need emergent cooling. Many times we do that with topical approaches. However, we have, just like with hypothermia, we have placed children on ECMO specifically for cooling purposes if their temperature is so high that we feel it's absolutely urgent. That is a rare occurrence, but it does require operative intervention as well. The other thing about that, again, is its impact on the electrical system. It can force a considerable load on the hospital to maintain appropriate temperatures in the operating room when the temperature outside is so high. That is a scenario where we have come into more trouble, where our generation system is taxed very heavily, and a heat wave causes the actual overall electrical grid in our region to be stressed to the point where we rely on generators occasionally in the summertime. And that is I think that is where heat waves are most detrimental to our system. Thankfully, the last time we had a major power reliability issue was many years ago, and our generation system has been working well. But here you can see the way that we have our the generation system in the United States arranged. There's overlaps between all of the immediately adjacent regions. So the Texas regional interconnection system interacts with SPP and CERC, which is this Southeast regional supply system. So we are able to actually flip to additional resources outside of our area if the temperature is so high that the electrical plants cannot generate enough electricity due to inability to cool their coolant adequately. So the other thing that we run into with heat waves is a lot of kids will go out to the beach and get sunburns, and we get them back usually in the clinics, talking to them about how to treat their sunburns. It's rare, thankfully, that we have kids in the modern era that get so sunburned that they need any form of this excision or grafting, but it's definitely a possibility due to this intensity of sun here from time to time. And then, as with everything, all of these types of disasters, hurricanes, heat waves, wildfires, can impact our supply chain. And that is where we find ourselves to be at our most vulnerable here at Texas Children's, because our operative volume is so high and our throughput is so intense for resources that we find ourselves constantly worrying about supply chain. So we have alternate backups and storehouses locally to kind of address some of these problems. And then we train. We do this, we do disaster training and organizational resilience training on a regular basis, approximately quarterly, because the philosophy is everybody has a plan until they get punched in the mouth. And then you don't want to find yourself without a backup plan. So, thank you. And I will stop sharing.
Thank you.
Mhm.
Thank you, Dr. Pryor. I learned a lot from that as well. And certainly heat waves are an issue where we live as well. And we had wildfires just before the pandemic. So lots to learn between us. Our last speaker for today is the esteemed Professor Wanga Debeti. Over to you.
To speak and I want to speak from a low middle income setting, where I live in Fiji, and look at the broad area of surgeries affected, not necessarily just the operating room. Now, this is the map of the South Pacific. So you see Australia, that's where obviously the two ladies are in, and the speck in the middle of somewhere there is Fiji. We are about 10,000 square miles in land area, but we are about 500,000 square miles in the sea. So we live in what's called the blue continent. So if you look at the international dateline, it goes smack through Fiji. And interestingly, because right through the dateline there, everything happens on the dateline. I don't know why. Everything happens on the dateline. So there's the islands. So there are about 300 scattered islands. There's about 120 that are inhabited over these 500,000 square miles. We are pretty good because the islands are a little bit big. Some of our colleagues in the Pacific, they're probably, the islands are about maybe 5 square miles, and they're in a 1 million square miles is the total space or the sea area in which that country is in. So over the last 10 years, I just want to concentrate on cyclones. And again, we're talking about cyclones and floods and together. Over the last 10 years, we have about 10 cyclones a year. These 10 cyclones, they've been growing. I remember when I was a child, we used to have cyclones that were about a category 2, category 3. Our cyclones now are 4 and 5. They're just becoming more severe. We've had 2 Cat 5s over the last 10 years. We've had several Cat 4s and Cat 3s. So Cat 3s for us now is like a norm. So those are the ones. So we're looking at Cat 3 to 4 and 5. That's not counting those who are Cat 1 and 2, because we don't think of them anymore. You also have to remember that because the islands are small, if Cat 5 is going through one part of the island, one part of the country, the other part of the country is feeling Cat 2, Cat 3 winds. And that's how, obviously, we are impacted by natural disasters. So Tropical Cyclone Winston was in 2016. 44 people died. We have a population of about 900,000. Nearly everybody is related to everybody, so we somehow knew somebody who died. But multiply by 10, those that injured, multiply by 100,000, those who were affected. So not including the fact that 35% of our GDP got wiped off. Why? Because we are heavily reliant on the tourism industry for our economy, and somehow the cyclone decided to go through the tourism belt. And so, afterwards, the infrastructure was bad. We couldn't have tourists for a period of time. And also numerous health facilities were damaged. We have about 300 health facilities, and numerous health facilities were damaged. The problem is, in a low income setting, it's not only the surgical component. Afterwards, there's a huge public health event that happens. So dengue fever, leptospirosis, diarrheal diseases, and these have an effect on the operating room because you have blocked beds, you can't get through to electives. So the cycle of inadequacy in being able to provide universal health coverage continues. So what do we do? So, I mean, ever since we are born, we're used to cyclones. So we've become better with the resources that we have. We have a national coordination center, which is in central government, and every ministry, including the Ministry of Health, works with them and through them. We advocate for funding in specific areas with multilateral partners for disaster response, and we focus and invest in disaster mitigation. At the moment, as I speak, there's more than 30 facilities. They need to be moved. They're either close to the sea, close to the river, close to a fault, close to falling, or close to sinking. And we train and train and train with our partners and friends from Australians and New Zealand. And obviously, that also meant that I spent quite a fair bit of my training in Australia, in New Zealand, as part of that program. We also have helping with our training for disaster management and also for how do we move forward and take the OR into places that need OR care, is we embed our surgeons, perioperative nurses into UN mission on deployments with our military peacekeepers. So they get also that training when they go to Golan, to the Sinai Peninsula, for example, and other places, such as, for example, places in Africa. So what happens during peacetime? During peacetime, what we do is we encourage the surgical teams to go on outreach visits and operate in small hospitals and try and build the capacity within the hospital. So these hospitals can be forward operating centers. We work through the Fiji Emergency Medical Team, and this became verified with WHO in 2019. So it's a type 1 WHO verified team that we use. And then based on the team, we can have what's called a FEMAT Light, which is a smaller team, branch out of the main Fiji Emergency Medical Team. We've now gone to pre-positioning based on the projected path of the cyclone. So if you know the cyclone's coming through a particular area or province, for example, we choose the health facility that's the newest and able to probably withstand the cyclone, and we send a light team to go and be based there and wait for the cyclone straight afterwards to start with dealing with the injured people, the open fractures, for example, the bruises, and the other injured people. We replenish, we train, and we try to be normal as much as we can and try and get through the electives. This is a slide comparing 2016 to 2022, looking at access to safe and affordable surgery, anesthesia, and obstetrics. And you can see in that wanting to move forward and ensure that we have access, especially during times of disaster, we've increased our accessibility to 80% from 67% within 2 hours to a bellwether capable facility. We have increased our workforce density, and we try and keep on increasing the volume of work we churn out. This is the Fiji Emergency Medical Assistant Team in 2019 in my previous role when we were verified by WHO, and recently, just about a month ago, they were re-verified again by WHO. And what does the team do? So there we go. So you have the team on your left lower corner, that's in the middle of the night, in one of the other islands where there was a Cat 5 cyclone they came through. We were still setting up camp. I was part of that group. At the top there, we have the team that's not only in Fiji, but also gone to other islands in the Pacific. On the top right, you can see a picture of the team working with the other coordinating facilities or central government. And then the lower right, we have a ship. It's called the Webueti. It's a barge. Based on the barge, we created a ship, a hospital ship. It's got 2 operating rooms. And after disaster, interestingly, after cyclone, the weather becomes really nice. And the sea is actually very, very calm. So we can swiftly sail to the islands that have been affected by the cyclone and offer surgical care. The problem is after the cyclone is the public health problems. So that happens afterwards. So this is, at the moment, we've had some really spate of bad flooding in the beginning of the year. So we've had 5,000 cases of dengue in 2022. After a cyclone, we had some leptospirosis and cases. And that's me in my previous role, after another role of cyclone, the cyclone coming through, advocating public health. And really what we have to understand is when there's a public health epidemic after a natural disaster, it really obstructs the ability to be able to perform at the operating room, because you can't admit electives. The intensive care or HDU is always filled with people who are very sick from the public health epidemic that happens afterwards. So the challenges. Challenge number one, we cannot change our coordinates. We are locked in at 180 degrees meridian. And so because we are locked in at 180 degrees, we get cyclones, we get floods. Challenge number two, we cannot actively pursue universal health coverage and sustain it as cyclones and climatic events arrest efforts. Challenge number three, post-COVID, there's been significant financial contractions, especially in low middle-income countries and small island developing states. And the cyclones and the climatic disasters and floods do not want to know that we've had COVID. They just keep on coming. So it becomes a vulnerable economic position. And therefore, there are significant challenges in the supply chain that we have, not necessarily because of the supplies getting to us, but the ability to actually lock in tenders, because obviously big countries, for example, can easily do that. And we are a small fish in this big ocean of logistics and supply chain. This is very important. Health needs the economy, and cyclones contract our economies. But we learn to be innovative, resilient, and focused. We love Fiji as much as you love the US of A. Thank you.
And that rounds off our trio of presenters. And I must say, I learnt something from every single one of them, coming from different backgrounds, but all facing similar challenges. And I think we've got a lot to learn from each other. I'm sure the attendees feel much the same. The key question that's come through the Q&A that I really wanted to pose to all three of you was, how do you prioritise care when resources are limited? You're keeping in mind that between Dr. Butcher's, Dr. Pryor and Dr. Wakana-Betty, we've got three really different levels of resource availability and different constraints. So whoever wants to volunteer to make a start on that, how do you prioritise what you do if you have limited resources?
I suppose it comes down to a triaging system of what's most urgent, what's going to be most valuable. COVID was very different for us than the floods. COVID cancer care was still being provided, but hip replacements weren't. So as a general surgeon, I did a lot of operating during COVID, whereas my orthopedic colleagues just did trauma, but no elective cases. And that was then, I suppose, flipped in a way during the floods, that the orthopedic soft tissue bony injuries were the main things that were coming through and having an impact on our patients. The cancer care, things like breast cancer, you could put them on hormone blockade while they were waiting for their surgery, and that's the things that we did. So it really it is a local response, and each disaster throws up different challenges that will have an impact on how you prioritize care for the patients.
I would say, interestingly, in our case, our limitation was personnel. The inability to get people here to get work done was our primary limitation. And so we had to be creative, although not necessarily with excitement, about working 24 hours a day, running, keeping the operations smoothly and persistently running through the night, even though that would not be our usual. We would not prefer to do that. taking advantage, setting up a smaller cadre of personnel, but all working at different times in the ride out team till all the work got done was the way that we managed things. And thinking, putting a thoughtful plan together for your ride out team is this big. How are you going to organize your shifts to make sure that you're working a even schedule all the way through the night and into the next day? I also actually, I was very interested to see the Fiji hospital ship. I served for many years as the director of surgery on the hospital ship, the Comfort, and was the surgical commander for the disaster response to Puerto Rico for Hurricane Maria. And we used that ship. It's the fair seas available make it possible to do all kinds of good stuff with a hospital ship when needed. I'd love to come see that thing at some point.
Well, this is true. I mean, I was sitting there thinking, well, Australia's got this long east coastline and we're getting our natural disasters. So, it would be really useful to have a hospital ship that could sail up and down. Professor Wangadabeti?
Yeah, I think every geographical locale is different. And it was interesting, hearing my other two colleagues talk about what they do in their setting, because really they, as I've said, in Fiji, we've been here, we grew up with cyclones, inundated cyclones. As a registrar, you get sent away to go on teams and EMT teams. And so every locale and geographical location, every system sort of knows what needs to be done. I think the only thing I want to share light is there are places in Australia, for example, that have, difficulty in access, for example, in the middle of Australia, probably the same in the US. And so they will probably face the same challenges we face in Fiji. We always joke, there's a picture taken of the Pacific at night, and you can see the lights on the coast of Australia, a lot of lights in America, but then nothing in the middle of the Pacific Ocean, and there's very few lights in the middle of Australia and very few lights in the middle of America. So we always joke where the lights are, is where the resources are predominantly. So I think it's there are places in Fiji, for example, if you live in the middle of Suva, you probably, and you have access to the hospital and to the big private hospital, you're probably, next to living in Brisbane, for example. But the majority of Fiji is not that way. So I guess we also have to remember that there's disparity within Fiji, and also there's disparity within big countries. And even in Europe, there's disparities, not necessarily in Eastern Europe versus Western Europe.
This is true. We've all got something to learn. Sally, you've got your hand up for one very last quick comment.
Oh, just to say that we were all wondering why the military weren't called in to set up a field hospital, or even our local AUSMAT team that goes out into other countries, and why they didn't come and support our local responses. And that's something that very hard when you're in the middle of things, that there are resources around that could be helping, but they're not deployed. And so anyway, that's just another government sort of bureaucracy issue that needs to get tackled.
Yeah, the federal state sort of coordination, and all things we can learn from for subsequent disasters, of course. That brings us to the end of our webinar, and thank you very much to our three presenters. I'll just hand over to Jessie now.
Thank you so much. And again, thank you everyone for taking the time to share your knowledge with us. I wanted to let everyone know that this webinar has been recorded and it will be posted on our ACS YouTube page. And you may also view any of the past International Relations Committee webinars under the Global Surgery playlist. Additionally, this year residents are allowed to become members of the ACS for free, and they can take advantage of all of the benefits of the college. And lastly, if you have any questions, feedback on this presentation, or ideas for future webinars, please contact myself or any of the International Relations Committee staff. Our information is on the screen. With that, thank you all so much, and we hope you have a great day. Bye-bye.